So we've now spoken about female genital schistosomiasis. We're moving on to another tropical neglected disease. This one is Leishmaniasis. And something tells me this is something I do not want in my life. Right? What is it? Where can you get it?
So, Leishmaniasis is caused by a parasite, and it can cause skin wounds that won't heal easily, or even a more serious systemic and deadly disease, especially in people with a poor functioning immune system. And it's found around the Mediterranean basin, in the Middle East, at the Indian subcontinent, the Horn of Africa, and in Latin America. And in Norway, imported cases of this serious form of Leishmaniasis are mainly imported from Spain.
Spain? Spain. Okay, so this is one of Norwegians' favorite holiday destination. Should we tell people to stay home?
No, I don't think so. An insect repellent would do the trick, actually. Okay. People are doing research on Leishmaniasis as well, and one of them is my PhD student, an eager parasitologist. Please welcome Senior Consultant in Medical Microbiology, Hanne Brekke, Oslo University Hospital.
So thank you very much for the nice introduction and the kind words, and thank you very much for inviting me to give this talk on Leishmaniasis, a global health threat of neglected tropical disease. So Leishmaniasis is caused by the Leishmania parasites, and there are several different parasites that are Leishmania. They're transmitted by sandflies that bite people, and it's endemic in more than 90 countries in the world. More than 350 million people live with the risk of contracting this disease every single day. And it's estimated that around 12 million people in the world have Leishmania, and they're suffering from it. This is one of the most neglected tropical diseases there is. It causes three main clinical entities, so the cutaneous leishmaniasis leading to chronic scarring that can even be lifelong. Around 1 million people contract a new cutaneous leishmaniasis every year, but only about 200,000 are reported to WHO. The next one I want to mention is mucocutaneous leishmaniasis, where the parasite invades the mouth, the nose, the throat, where the subcutaneous tissues and the cartilage, and it partially or totally destroys this cartilage, leading to destruction of the bones and the subcutaneous tissue. So the patients are at risk of contracted serious secondary bacterial infections or viral infections, and it's very important to treat this. And then, as Frank mentioned, one of my main supervisors, visceral leishmaniasis, which is the organ manifestation, also called cala-asa. And I'm going to mention that a little bit more later. But if you've had cala-asa, you're being treated for it, you can also develop a sequela from it. About 6 to 12 months after apparently being cured, you can develop post-cala-asa dermal leishmaniasis, where the patient develops macules or papules or nodule rashes all over the body, where they contain small parts of parasites, and they can uphold an infection and transmission spreading. And of course, you can also be an asymptomatic carrier of the parasite not having any symptoms. But visceral leishmaniasis, the most important, the most deadly form, is caused by the Leishmania donovani complex. 90% of the cases in the world, they occur in Bangladesh, Brazil, Ethiopia, India, Sudan, or South Sudan. And some of these countries are some of the most poor countries in the world also, and people live very much in rural areas, and they're hard to get to the clinics. It has 95% or above 95% fatality rate if you don't get treatment. So this is a very serious disease. Co-infection with HIV is also very important and is a major problem in a lot of these countries. And both the visceral leishmaniasis and the HIV sort of complicate each other and make it even difficult to treat both of them. Every year, around 50,000 to 90,000 new patients contract this. but only about 25 to 40% are actually being reported. So there is also a big underreporting on this. WHO has a group on neglected tropical diseases, and I'm fortunate to be part of that. And they have developed a database where we can plot in cases, and you can see it in the app. And I sort of suggest people go in and look at this further, because that gives very good data. But to diagnose this disease, you must have clinical suspicion. Then you can do microscopy for the mastigotes, which is on the top picture, or you can do culturing for the promastigotes, and that requires special media. You should keep it around 24 to 26 degrees continuously, cultivate it for up to 4 weeks, and altogether, microscopy and culturing has somewhere between 60 and 85% sensitivity. And it cannot be used for peripheral blood. You need to have bone marrow, spleen, or a biopsy. And if you have a biopsy, there's often less parasites in it, so then you have a lower sensitivity. And this requires a lab and highly skilled trained personnel. Serological tests can be very good. They can detect an infection or of a visceral leishmaniasis, or they can detect an asymptomatic carrier, or they can detect that you had the disease in the past, but they cannot differentiate. And you cannot use it for cutaneous or mucocutaneous leishmaniasis. So it has a lot of limitations. And this also mainly requires a lab with platforms for serology testing. But there has been a development, so you can get dipstick tests for the field use, but again with the same limitations. So in most Western countries, PCR has become the gold standard. PCR is excellent for detecting leishmaniasis. It is very good sensitivity from 92 to 93%, up to 98%, can be used on all tissues, including peripheral blood, even when there's low amounts of parasites, and you can detect the species, which is important when you're deciding treatment later. But you require a highly skilled and well-equipped lab. So in a lot of research protocols and a lot of different settings now, they're trying to develop nucleic acid amplification tests, such as LAMP or RPA, where instead of having a thermal cycling, you use an enzyme to do the amplification. And these tests are something that we're working on, and you can bring them out into the field to actually reach the patients. To treat leishmaniasis can be very difficult, and I just want to mention this. There are only 4 different groups of medications that can be used for visceral leishmaniasis. Pentavalent antimonials, been around since 1920. Primamycin, hardly available in most countries in the world. Amphotericin B, not that good, highly toxic, so it's mostly used liposomal amphotericin B, which can be very good, but there have been limitations in getting this medication. All of these 3 mentioned, only given intravenously, so you need hospital facilities or something like that to give it to the patients. The next drug, miltefosine, is a promising medication. It's orally taken, but also very difficult sometimes to get hold of. And all these 4 medications, they have limitations in the fact that there are reports of people not having treatment failure and not being able to be cured by it. And there are reports of recognized antimicrobial resistance to all of them except for parmamycin. And that's probably because it hasn't been used that much so far. If you're contracting leishmaniasis, it can be associated with malnutrition, particularly vitamin A, iron deficiency, or protein malnutrition, a weak immune system. And both of these, they tend to sort of make the patient more available to develop a full-blown disease or have a patient who is a carrier transform into a full-blown visceral leishmaniasis. Poor housing or poor sanitation, good breeding grounds for the sandflies and then, spreading of the parasites. People crowding, more people to bite, easier for them to reach them. Sleeping outdoors, which is fairly common in quite a lot of these rural areas because they're, looking after their herd or something. You're more easily bitten. Then the lack of financial resources, people might not be able to go to the doctor or take the test, or the population displacement, which happen due to famines, or, for instance, in Ethiopia, where there's been a war, that increases the risk of spreading infections. And also the environmental changes, the climate changes, leads to new grounds where the sandflies can exist and the parasites spread. And we have seen this in Southern Europe. And epidemics with this typically occurs when a group of non-immune patients or people move to areas where there is a high transmission. So intervention measures, they need to be both for the individual patient and for the population. So for the individual patient, it's super important with early case detection, clinical diagnosis, correct diagnosis with the laboratory, and then correct prompt management and management of complications, and then prevention of further problems to reduce the risk for the single patient and increase the prognosis. But for the whole population group, it's still important with early detection and effective treatment of the single patient, because that reduces the parasite load in the community. It's important with vector control to stop the biting. So it's also important to not just reduce vectors, but stop the transmission cycle. It's important with effective disease surveillance, so that patients are being recognized, and when there is a potential outbreak, you can put in quick and prompt measures to prevent it spreading further. And it's also then important with the control of reservoirs, so it's important both with recognizing all these asymptomatic carriers or the other human reservoirs as well as the animal reservoirs. And it's important with mobilization socially, with education of the communities and strengthening partnerships between non-governmental and governmental organizations to encourage to educate people on this. So WHO, they're working quite a lot on neglected tropical diseases and Leishmaniasis, and they have said that ending the neglect, it's important to attain sustainable development goals. And to achieve this, it's very important to recognize that this disease, Leishmaniasis, is a One Health problem. It must be seen in a One Health perspective, and we must work in multidisciplinary teams. Research on NTDs and Leishmaniasis has been severely underfunded, with delay in new knowledgement, delay in scientific breakthroughs, and it is also vitally important that governmental bodies recognize this and that improved funding come about. So, WHO, they have recognized some research gaps, and that can be epidemiological data, which there is a lack of, transmission modes, risk factors, socioeconomic impact of the disease, control and elimination rates, improved diagnostics, particularly rapid diagnostic tests for field use, and also improved treatment regimes and case integration and management. And it can be reporting and antimicrobial resistance reporting, as well as detection and evaluation of complications of the condition. That includes disabilities and mental health issues, because it has been reported that a lot of these patients, particularly actually the cutaneous Leishmaniasis patients, they develop severe mental health issues because they have scarring lifelong, and that leads to problems and stigma in the community. And also, it's important to coordinate all this work between the different partners that happens. So for us, that has led to our research with my main supervisor, Frank, who's there, and Arne Takst, who's sitting in the back, and then my boss, Fredrik Müller, and Nega Bere in Ethiopia. So we are establishing a point-of-care nucleic acid-based test. So it's a LAMP test that uses an enzyme for the amplification to detect the Leishmania parasite. And it can be done on peripheral blood and tissues and even cell papers that can be collected in a field setting and brought to us. But then again, the test itself is very small, about 5 centimeters by 10 centimeters, and it can be brought out in a car to a school, to a field setting and used there. And what we're developing is a test that can be quantitative so that we can use it both for diagnosis of the disease, but also as a quantitative test to see if the treatment is working. So we can use this as a test of cure, which is not that common for most of the tests. For that, you need PCR, basically. And we're planning to do an epidemiological surveillance study in a highly endemic area. And then we're planning to do establish a sequencing method for antimicrobial resistance and do surveillance studies on this. And we're fortunate to then have international collaborations to work further with this. In addition, we're also, some of us, part of the WHO working group on neglected tropical diseases, so we're happy to sort of have input from them also. And thank you for my presentation.
Thank you so much.